My name is Dr. Edward Ngwenya, and we continue with our podcasts of plastic surgery. And herein, we continue with our series on breasts. We last spoke about the anatomy, the development of the breast. Important to listen to that before you listen to this. Excuse me, this series. However, today we will be discussing mammoplasty. So these are patients with large breasts, and we can say hypermastia or macromastia would be the discussion for today, and how to manage these patients. So we'll just group it into the pathophysiology, what are the indications, and then here's a patient, what are my preoperative considerations and the issues that I'm going to highlight in my consent, and then we'll go into the procedure in itself, how to approach the technical elements regarding the incision, the pedicle, and the choices thereof. Perhaps we can also just touch on what the word gigantomastia then is, and what the indications would then be for now a free nipple graft. And then we can maybe just speak about a patient who then comes in. You've done a PBR, you come back, and you need to do a repeat PBR. A PBR is a bilateral breast reduction, mammoplasty. So we come back, how do you then approach that patient? And then what are the complications? Some of which a high riding nipple is one of them, and you need to be able to have a handle on dealing with it. Again, I always mention this is a high level overview. It's impossible to teach the technical elements of mammoplasty in this audio series, and so it's important to have a firm grasp of understanding, look at the pictures, practice some of these in theater, and then this will just cement some technical elements just to assist you when approaching exams as a resident. So let's start. What is the pathophysiology of hypermastia? Something we don't generally know so well. What we do know, look, the estrogen levels and the number of receptors you would find generally are normal. The number of the receptors they're in. So there is a suggestion that, look, there is an abnormal excessive growth secondary to circulating estrogen. So the estrogen is not necessarily high. However, there's just an excessive growth in response to the circulating estrogen. Primarily, what we note from our specimens is that there is an increase in fibrous tissue and fat, which actually makes up 48 to 61% of modern breast reduction specimens, but relatively a smaller increase in glandular tissue. So the hypothesis then would circulate around that. Of course, there is no data to support that weight loss, is an effective treatment for, hypermastia or breast hypertrophy. And so it's very difficult. However, we know that outcome studies have shown as, quite good symptom relief for both obese and non-obese patients. So have a look, read about it, but those are just some of the things that are thrown as the pathophysiology of hypermastia. But what we do know is certainly the indications for reduction or surgical intervention in these patients would be patients who come in symptomatically. Of course, there's the cosmetic side, aesthetics, but the patients may come in with relative symptoms. What are those? Back pain, neck pain, shoulder pain. They may even have a scoliosis. They may be drooping as they come in. They may have chronic headaches. The straps around the brow area, they may form marks. There may be even, numbness in the upper extremities, generally the ulnar distribution, and you may find, tail telling signs when you look at the skin with the intertriginous infections. There may be rashes, there may be maceration. It can go as far as having cervical or thoracic degeneration joint disease, the DJD, in very extreme cases. But generally, these patients really struggle, with their wardrobe, with exercise, and so they would come to you to seek help therein. To see if you can assist. It is a long history that's come back from the early 90s or 1920s, where it was managed by free nipple graft techniques. And of course, we've evolved, as you will see, going through different techniques where we then come in. Up until, even in 2005, you would see Hamdi, who uses the septum of Warrender to maintain vascularity and resection, or rather sensation of the NAC. So we've gone a long way with this. But perhaps let's go in and say, here's a patient who then comes in. And when they come in, they then want to get some form of idea from you on how this process is going to unveil. So the way you're going to assess and generally counsel a patient is by going through your pre-operative assessment and ticking some concerns that you would have on history and on examination, explaining your intraoperative concerns, both locally and systemically, and then explaining what your complications would be, your post-operative concerns on an immediate side, and also on a more delayed or late presentations. And so we'll then just discuss briefly what our considerations would be. Of course, on history, age is very important because it will give you an idea. And we'll speak about a condition known as juvenile, juvenile, Macromastia. And how we would then manage that. So you want to know how old the patient is. Just take a history, look at those, and take if it's symptomatic. Of course, we know we're dealing with the breast, and the most common cancer in females is breast cancer. In fact, we've got 14% as the lifetime risk of a woman developing breast cancer. And so breast cancer risk factors are important, and the screening thereof. And you want to know previous breast procedures that were there. It's important, to know about the reproductive history. What are the future plans on pregnancy, as we'll explain the issues that may have with lactations. What is the psychological or psychiatric state of the patient? What are their expectations? What's the current bra size? What do they want then? These are important things to consider. Comorbidities you cannot live out, and pharmacological history, including social history, very important. Is the patient smoking? This is plastic and reconstructive surgery relying on blood supply, and so we know the effect of smoking, on a nicotine level, what it does to our vasculature as well. And perhaps just take a history if the patient's able to receive bloods. As you know, some patients who are Jehovah's Witness may not be able to receive blood, and you may blood products, and you may find that a patient bleeds. So it's important to take those details. BMI, very, very important, as we do know, even though we know mostly in practice, stretch the BMI, but ideally we don't want to operate on patients with a BMI greater than 30. And of course, you're going to find patients who are very short, unlikely to really change a BMI. But look, I'm giving you the guidelines, and guidelines are just guidelines. It would be for you then to determine. So others may stretch and operate on a BMI of 33, but we know the complications certainly increase. But on your assessment, you go through your normal breast assessment. I'm not going to go into checking the asymmetries, the breast size, what the NAC position is, IMF, chest wall, look at the spine at the back, palpate for masses. check the axilla, and of course we've got guidelines as per the classic pen numbers of what the ideal breast generally should look like. But dealing with patients with hypermastia or macromastia, you generally are going to have large breasts. And explaining intraoperative concerns, both locally and systemically. Of course, on a local element, we're worried about bleeding. When you dissect, you want to make sure that you bevel out, with your pedal. You want to check, depending on the approach that you use, maybe superior medial or medial, as you twist the pedicle, check for kinking, minimize thinning the pedicle too thin. Your skin flaps also, making sure you've got adequate and you're not going through skin and there'll be adequate blood supply, the symmetry that you look for, because your markings are very important as a guide. And so it's important to learn your markings so that you can achieve symmetry. Closure, make sure you want to close in at least 2 layers, the NAC position where you would like it, and we'll go into some of these and choose whether you're going to use a drain or not. Some don't use a drain on a safe aspects. Perhaps you may look at it, but there are various studies. I use a drain all the time, but their way Corion, Matarasso showed that, look, there's no statistical difference in terms of the complication rates. If you look at NGAN, Ngran, and his colleagues, he concluded that less than 50 years old, when you look at those patients who are less than 50, who came from a breast reduction of, and you remove less than 500 grams, you may not need post-operative drains. But I use drains. But important to note, drains do not prevent a hematoma. However, they may reduce the substrate for bacteria, but they may also alert you of a bleed, a hematoma that is collecting there, and maybe intervene faster. But generally, I find it safe to use drains, but knowing that others may state that you don't have to use drains. Now, systemically, explain the anesthetic process, the risk of DVT, fluid management, operative time. All of these cumulatively can add to increasing complication rates. And the complications must be, you said to the patient, immediate post-operative concerns, locally a hematoma, the nipple areola complex might be compromised. Compression is a big one. Systemically, you may have a DVT or post-operative nausea and vomiting. And of course, there's a criteria when you look at the patients who are most likely to have post-operative nausea and vomiting and how to manage them. Pain is a big one. And then early post-operative unfavorable results also to look at, 0.5% of the patients will have the NAC compromise, but also you must explain that there may be a seroma, there may be infections, there may be mispositioning of the nipple areola complex, and late complications. You may have issues with the incision, where you may have inclusion cysts, you may have granulomas, unsatisfactory scarring, especially our population group, where you may have hypertrophic scarring, and that's 4% of patients in one study. The nipple areola complex as well, you may have altered sensation. Generally, we have a figure of 9 to 25% of patients would have that. Breastfeeding, a third of the patients would have. We don't know. Generally, is it because of the operation? Likely. Or it's generally a third of the population maybe just may not breastfeed, but breastfeeding is one that is raised, and the malpositioning as found by Ahmad, I think, and Lister, where they found that the NAC within 4 years after surgery was generally located on average 1 centimeter higher compared with the planned position. by your preoperative skin markings. So this usually can happen, some would say, with the bottoming out, etc. But malposition is one thing. And parenchyma, it's important to know, fat necrosis, there may be asymmetry, you may have insufficient reduction, there may be persistent pain, over reduction you can also have, and with a change in the breast shape over time. These are things to explain to a patient before going in to operate and have a bilateral breast reduction. So these are just some of the considerations that you will need to go in and speak to the patient explaining. I won't go into the details of some of them. So now that we know the pathophysiology, perhaps we can then look at the operation in itself. Also, as you counsel a patient, would need to then classify the way would then do the operation, and that we classify on the type of incision that you will use, and then we classify based on the pedicle that you would use. So when we look at the incision, or the skin rather, there are different incisions that you can use. Maybe I'll give you 5. Let's see how many I remember as we go. There's the keyhole, or your anchor scar, or your inverted T wise pattern incision that you can use. There's the B-shaped incision by Rignall. There's the vertical, explained by Lassus, Lejeune, Hall, Finlay. There's the short lateral scar by Machak. There's the periolia, Benelli, vertical scar. So there's many different techniques that you can then use. But generally, the way you would then, try to use those I like to divide it looking at the skin envelope, looking at the volume that you want to take out, the parenchymal volume, and looking at the nipple areola complex, where it is. And that is what I generally use as a guide into, operating this. For example, for a keyhole wise pattern incision, if you look at your skin envelope, if there's a lot of laxity, and you've got a lot of skin redundancy, it's perfect for that. Parenchymal volume, it provides access to all the quadrants. You are able to remove quite a lot of tissue, and I would use it where I've got, grade 3 ptosis, quite a lot of ptosis, because you are able to reposition your nipple areola complex quite well, but also deal with the skin laxity. So those are the advantages. Vertical scar is explained by Lejeune, Horn Finlay. Skin envelope, it requires actually quite good elasticity, not too much laxity, but you may have some. And generally, if you read, it will tell you it's for smaller reduction, a maximum of 2,000 grams. You would then use it for that. However, as I'm mentioning to you, these are guidelines, and of course you will find papers where some people may tell you they remove more, etc. But this is what, and with a moderate level of ptosis, then you can use that. The perioreola Benelli, generally, if you've got too much skin laxity, I find not great, it won't work. You require good skin elasticity actually, and for very small reductions, and for ptosis as described classically, less than 2 centimeters. Then there's the no vertical scar pattern, the perioreola and inframammary scar only, where you can use for relative laxity that's there. And most of the resection you'd find can be laterally, but for ptosis greater than 5 centimeters, it's in, if you read literature, it describes as that. There's the short lateral scar technique. There's the B shape by Rignall. There's the spare technique, skin envelope. You've got normal to, relatively good quality of skin, and for hypertrophy, mild to moderate, removing less than 1,000 grams, and mild to moderate ptosis is where you would like to use these these incisions, if I may say. So the incision is one, and remember, I'm just giving you the broad basis, but of course, these are just guidelines, and there are areas where many people have stretched these. But generally, a wise pattern tends to work well, especially for our profile of patients that we would get, and generally, it's one that you would be safe to use and giving you access. So then after we've looked at, the skin, we look at the pedicle. And that's how we then classify our breast reduction. You can use a superior pedicle, which is described by Dr Ngwenya. You can use a superior medial as per Orlando. You can use an inferior pedicle as per Cortés or Ribeiro. You can use a superior lateral as per Skog. You can use a central mund as explained by Hessner and Bisenberger. You can use a horizontal bipedicled superior and inferior as per Stromberg, or you can use a vertical bipedicle as we know it as per Machisok. So generally what you must just know, not important to remember names, but just to know the pedicle that you use, what blood supply would you rely on. We've gone into different blood supplies, but just to give you an understanding, for the superior pedicle, it's the second intercostal space. That's where the blood supply will originate from. And there's a large descending branch which actually curves over the breast and enters the areola, and that's about a centimeter deep to the skin, and very close to meridian. So you must just look, and that's why you are able to thin the flap or the pedicle with a superior, including the superior second intercostal space, intermammary perforator there. There's the medial pedicle, which originates at the third interspace. I'm not going to go in detail. You will have a look at these and where they are. But these vessels are quite superficial at the level of the areola, but they are deep, close to the sternum there. So you can also quite thin your pedicle, very nice. Of course, there's the superior medial, where you can then, it would include the second and the third. There's the lateral pedicle, on the other side, which generally originates from the superficial branch of the lateral thoracic artery. And what you must just be careful about this is that really it can enter the breast at a very, very, fairly low level. And a lateral pedicle, as you design it, should be designed with a low base, just to ensure that you really include this artery. And you'll find that the branches also run in this Warringer septum that we then spoke about. It is also quite deep in, at the periphery, but becomes quite superficial as we get closer to the areola. There's also now the inferior pedicle, which is one that you can use, or the central pedicle, which originates from the fourth space. But of note, look, there are also vessels that curve around the inferior aspect of the breast, from the fifth and possibly the sixth interspace, and enter the breast at the level of the IMF. And generally they also have a deep origin and curve around to enter the breast in the superficial subcutaneous tissue. The bipedicle, of course, would follow then those as per Machisok and Stromberg, being the horizontal, or rather being the vertical and the horizontal, respectively. So I'm not going to go into the benefits of superior medial pedicle versus an inferior pedicle. Generally, what I've found is that, those are generally arguments between us as plastic surgeon. This one is better because you've got dual blood supply as an inferior pedicle. Actually, if you look, it preserves lactation 72% potential, and you can remove more from the quadrant, while the other superior medial, no, this one you can thin the flap, and as per Van Deventer, it's actually the most reliable vessel, blah blah blah. We'll argue those points, of course, and there are studies that have been written where you can look at those. But in general, what I found, breast reduction patients with macromastia at the end of the day are happy. Whether you view superior, medial, inferior, they are happy. And they actually don't know those arguments. And it's just us who argue. But certainly good on a scientific, academic side to look at those and try to have many tools within your hands because, and individualize it to the patient. Because when, you only have one tool, then every problem, if your only tool is a hammer, every problem really is a nail. So you need to be able to differentiate and use it specifically to your patients. I think that should cover it. Perhaps an important aspect that we need to know about is sometimes you may find very, very large breasts that you need to then reduce, and generally would call that gigantomastia. Gigantomastia, very interesting term, because if you read literature, there's not actually an agreed weight or definition for it. Some have used as low as 800 grams. Some have used 1.5 kilograms, and others have said if it's greater than 2,000 grams. So gigantomastia would generally say anything between 1.5 to 2,000, and it seems relatively accepted that greater than 1.5 we're dealing in this case then with gigantomastia. And then the way we then need to manage gigantomastia is a bit different. And so that's when now you may find a situation where you may need to then use a free nipple graft for these patients. So which patients are you then going to decide, I'm not going to go for the conventional pedicles. This patient, I'm going to use a free nipple graft. By the way, I'm not going to go into liposuction, how you use it, Sonak assisted, etc. No, you can have a look at those on your own. But we're looking at gigantomastia now, and generally, your indication for a free nipple graft would be quite a large breast, as we've mentioned, that requires a resection of more than 1.5 kilograms or more of breast tissue per side, per individual side. Classically, you'd get a measurement such as if you have a sternal notch to nipple that's greater than 40 centimeters, already you should be doing a free nipple graft. I can tell you, these are guidelines, of course, and you should remain safe and know the guidelines. However, we've stretched it in my institution, and done, performed BBRs, and we do it with, external notch to nipple, grade E up to 50 with good results. But those are certainly the guidelines. Greater than 40 centimeters, you should consider a free nipple graft. Also, if there's this a previous operation or chest wall radiation that may impair blood supply, others would list that as an indication. And if there's the type of patients, because remember, we don't operate on breasts, but we operate on the patients with large breasts. And so you look at the patient holistically. And so if, complication factors such as maybe age, systemic disease, comorbidities, where other areas where we expect significant blood loss and we want to minimize the operation time, you may then need to go for a free nipple graft. But just know, generally, it may give you an unnatural appearing breast, but you are able to position your NAC. You are able to get less theater operative time and actually cut down on a whole lot of those, minimizing the complications. However, you do have the complications that the NAC in itself may not take. It may desquamate, and you have depigmentation, even not completely, but spotty areas of the graft may fail. And so you really have to be meticulous in the way that you are going to do a free nipple graft. How you perform it, I'll leave that up to your reading. You should know how to. We're not just amputating the breast, but there is a form of a technique and how you can do this. And you can just have a look at that and read about it and around it, and just go with the senior consultant who's done this, so they can show you how you may do this. Now, look, there are times when you're going to have a patient who comes in and who has had a breast reduction before, and now comes in for a secondary or a repeat breast reduction. And I like to refer to Rorik, who did an algorithm, particularly regarding that, and says the way I suggest you manage these patients is take a history, and if you've got previous clinical records, please go have a look at those. And you want to basically divide your patient into three main groups. Is it inadequate primary excision? Is a recurrence? Or it may be juvenile macromastia, of which he recommends for juvenile macromastia, you do a reduction versus, you may also be pushed to do a mastectomy and unilateral or bilateral reconstruction. So that's one of the areas. But we'll discuss juvenile macromastia when we discuss our topic regarding different breast conditions. But if we've got a recurrence, or you suspect there was an inadequate primary excision, of course you do your general examination, send these patients for a mammogram. You want to exclude other pathology, and if there's something you pick up there that's suspicious, you are going to biopsy and treat accordingly. But let's assume we've got an area where we've got diffuse macromastia. Remember, you may have pseudotosis only, and for those, an inferior wedge resection can work. But here we've got a patient with diffuse macromastia. So what do? We then divide it as per Rory. He says if it's less than 500 grams that you expect to be reduced on each side, and the NAC position is satisfactory, then you can perform a reduction based on a primary or the primary pedicle, if you know the primary pedicle. If you don't know, you can do an inferior wedge resection or, consider liposuction. And then if it's more than 500 grams and the NAC requires repositioning, then you may approach it in one of two ways. If you know what the primary pedicle was, then you do a reduction based on that primary pedicle. You may consider using, an adjunct of liposuction, and he advocates for that. But he says, look, if it's greater than 500 grams, NAC requires repositioning, you don't know the primary pedicle, you go for a free nipple graft. And that's as per the algorithm by Rory, published in PRS 2002. Of course, what I would like you to know is there are other ways to look at it. Remember, these are the guidelines as proposed by Rory, but we've played around and, gone for different. He tried using bipedicle, which works very well, that you go. There are others who would strongly suggest you must do a bipedicle. And then others would say, no, look, even if it's more than 500, if you go for the known pedicle and the same one, you should have good results. However, know the controversies and know what the guidelines really state in how you can manage these patients. Perhaps, yeah, as I've said, the juvenile breast hypertrophy, also known as vaginal mammary hypertrophy. It's a condition, just to keep at the back of your head, where you have rapid enlargement of one or both breasts that's usually present in the adolescent years. But this generally is a diagnosis of exclusion. Make sure you exclude other things, fibroadenomas, which we see very quite often in younger patients, giant fibroadenoma, fibrocystic disease, phyloides tumor you may find, or other endocrine conditions. And so it's important for these patients that you want to make sure you check the hormonal levels, and if they are abnormal, you may need to do a CT head and pelvis just to see if you've got possible endocrine abnormalities. And some of these patients you may need to consider actually tamoxifen if you find that they're abnormal, without any pathological anatomical findings. There are others that you may need to do where you find that the hormone levels are normal. You may need to just do a rheumatological evaluation, and if you find that they are abnormal, you would then also consider adding rheumatologic treatment as required. But generally, if you find there's no problem, these are patients that you then need to look and see how you are going to manage. And we still have the same tools that we use as per the skin excision and the pedicle that we can use. There is a study by Hudson and Landau in 2008, PRS, which looks at superior middle pedicle for Gigantomastia and advocating how it works very well. So just keep those and be able to answer those questions. I think we've gone through the complications. We've gone through the operations and what to expect as complications. Perhaps one complication that we may just need to touch on is a high riding nipple. And generally, the reasons for this, maybe you may divide it as absolute or relative displacement, where you may find that your preoperative markings were placed too high, or your limbs were just too long, or there was bottoming out, especially when you do the inferior pedicle. And so thus the breast sags and the nipple is pushed higher, this being relative, as found by Ahmad and Linsa, as I've explained to you, that they found that the NAC after 4 years actually was higher by 1 centimeters. And so the way to prevent this is generally you rather mark with your markings you rather have the NAC placed at a lower position than higher. Lower, we can at least deal with it. You want to, as you mark, you can shorten your wise pattern limbs in order to have your nipple lower. And though undesirable, I don't like to mention this. I've seen it on other papers, because we don't like to tamper with the IMF. Others say, you can raise the IMF, but we usually don't like to violate the IMF. But ensure that there's sufficient skin for the upper breast border, and make sure that at least on a minimal you have about 8 centimeters that's planned from your IMF position. And so those are the ways to prevent it. So let's just quickly go into managing it. How will you manage it? Remember, we said you can use either direct or indirect strategies. Indirect strategies, you can elevate the IMF and breast parenchyma. So indirectly you will lower it. You may the superior breast, you may add some volume to the superior breast, or you can reopen, just go back, reopen, and shorten the wise pattern limbs. Those are just some of the indirect measures that you can use. Direct measures, excision of adjacent skin. You can then graft. Just say, I'm going to resect and I'm going to graft my NAC to a more favorable location. Or you may choose transposition as a flap to transpose your NAC. Those are some of the measures. But if you read what you may find as indications for indirect strategies would be, a normal to near normal nipple to standout distance, a long nipple to IMF distance. You generally want something greater than 8 centimeters. A bottom out breast, implant with the device sitting below the IMF scar, or a depleted upper pole. Those are some that you can use, and they can be classified as relative malposition. And also inferior breast resection is something that you can use there, where wedge resection of the inferior breast parenchyma is used, and then you may then go for superior breast volume addition. This is just upper pole expansion. Whether you're going to insert an implant, you're going to do lipo augmentation or tissue expansion, if the skin envelope will not accommodate any additional upper pole volume before you put in a definite implant. So these are some of the things that have been noted. For direct indications, of course, a short sternal notch to nipple distance, or if you've got that combined with a reasonable nipple to IMF distance, that being 5 to 7, you classify those as absolute malposition. So if you've got absolute malposition, options: excision of adjacent skin graft you may do to a favorable location, or transposition, whether you are going to use a VY, inferior nipple repositioning, reciprocal transposition flaps that you may then choose to use. And then just others would say maybe also you can use what you call hyperbaric oxygen post-operatively for ischemia to assist. But generally, what I've found is when the nipple malposition is caused by elements of both relative and absolute, generally it's preferable to correct the position of the breast wound first before anything else. But those are just some of the strategies that you can have when you are confronted with a high riding nipple. And I think that should cover Macromastia for us. And just to remind you, always you go back the pathophysiology, you go back to the indications, and then pre-operative evaluation and counseling, very important. Going right through to the pre-operative phase, intraoperative phase, post-operative phase, complications, early, late, undesirable outcomes, early, late, and then to just know when, how am I going to classify my operation, what incision will I use and what pedicle will I use, and when will I abandon this and just go for a free nipple graft, what are my indications, and how will I approach a patient who comes back for a repeat BBR, and how will I deal with complications that I get, one of which is a high riding nipple. I think with this, we should be able to at least have a firm grasp of how to deal with Macromastia. Thank you for joining me. I look forward to the next presentation as we continue with our breast series. The next we'll be talking about breast conditions, but also look out for the Gigantomastia and look out for augmentation and breast cancer and reconstruction. Those will follow. Take care. Bye-bye.